Hi guys, welcome back to my channel. In this video, we are going to study pneumonia. The overview of pneumonia is we will study the definition of pneumonia, the pathology, pathophysiology, the types of pneumonia, and also their clinical manifestations. And lastly, we are going to study treatment of pneumonia. So, what is pneumonia? So basically, pneumonia is defined as the inflammation of the lung parenchyma that is only of the alveoli, not of the bronchi or bronchioles. So pneumonia will basically affect the alveoli, not the bronchi or the bronchioles, and this pneumonia is characterized by consolidation. So what is consolidation? Consolidation is a pathological process in which the alveoli, the whole alveoli, that is the sacs, are filled with the mixture of some inflammatory exudates like some cytokines or any of the inflammatory mediators, bacteria along with WBCs, that upon chest x-ray, when we take chest x-ray, so this alveoli will appear as an opaque shadow in the normally clear lungs. So this is this is about pneumonia and its consolidation, how pneumonia exactly looks under chest x-ray. So this pneumonia is basically classified into three types, that is community acquired pneumonia, that is the pneumonia which is acquired from community. And the next one is hospital acquired pneumonia, the pneumonia which is acquired from hospital stay. And the third one is pneumonia which is acquired from ventilator. So the third one is ventilator acquired pneumonia. So now we will study the pathology of pneumonia, how exactly the pneumonials or the patient who is suffering from pneumonia, how exactly the alveoli or the lung parenchyma will look like. So pneumonia evolves through series of pathologic events. There are actually four phases, that is the edema phase, red hepatization phase, grey hepatization phase, and resolution phase. As we can see here in this picture, the first phase is edema phase, wherein here in under microscope the cells are seen and those are edematic, meaning they are filled with some fluid. So this phase is the presence of proteinaceous exudates, often of the bacteria. So this in the phase 1, the alveoli is filled with some proteinaceous exudates which is often from bacteria, not specifically with the virus. So the second phase is phase 2, which is red hepatization phase. So in the second picture, it is clearly visible that the cells are little bit red in color, which means presence of erythrocytes, meaning RBCs, in the cellular extra-alveolar exudates. So in case of red hepatization phase, what happens is the alveolar or the alveoli which is filled with erythrocytes. Okay, so it is filled with erythrocytes. And the third phase followed by is grey hepatization phase, means the red phase, the erythrocytes are clearly, they are cleared now. So only the presence of grey color. So in the third picture you can see here, it is fully grey in color, meaning there is no erythrocyte present or no RBCs present. Here it says no erythrocytes are extravasating, and those already present were already lysed. So they are the RBCs which are present in the phase 2, they are lysed and they are degraded. Only the neutrophils are the predominant cell. So only the neutrophils are present, whereas erythrocytes are degraded and they are lysed. They are killed. So the phase 3 is followed by phase 4, which is resolution phase, meaning the debris of the neutrophils, bacteria are cleared, meaning the phase 4 is characterized by the clearation or clearance of the neutrophils or bacteria or any kind of debris which were present in the phase 3. So this is about pathology of pneumonia, the stages involved in the pathology of pneumonia. Next, what is its pathophysiology? How will the pneumonia act on the body and how body will respond to pneumonia? So we will be studying in detail now. So pneumonia results from proliferation, meaning division, meaning kind of division of microbial pathogens at the alveolar level, not in the bronchi or the bronchiole level, only at the alveolar level, and the host responds to those pathogens. So it basically results from proliferation of microbial pathogens at the alveolar level and the host responds to those pathogens. So this is pneumonia in sum up. The pathophysiology is sum up in this line. So what happens exactly? We'll see now. So bacteria, when it enters into the lower respiratory tract of the individual or the host by aspiration from oropharynx. So basically the first step which is involved in the pathophysiology is bacteria will enter into the lower respiratory tract, that is the larynx, pharynx, by aspiration, by inspiration from oropharynx region, meaning the oral and the larynx pharynx region. Bacteria will enter into the lower respiratory tract. The hair and the turbinate of the nostrils, obviously there are hair present in the nostrils, those will capture the inhaled particles, which is a kind of first defense mechanism. So when the bacteria enters into the nostrils, so the hair which are present in the nostrils will capture the larger inhaled particles before they reach the lower respiratory tract. So this is the primary mechanism, primary defense mechanism. So hence it will allow, the hair will allow the inhalation of the particles before they reach the lower respiratory tract. So the branching architecture of the tracheobronchial tree traps the microorganisms or the microbes or the pathogens on the airway lining, where the mucociliary clearance as well as some local antibacterial factors which are present in the tracheobronchial area. So they'll either kill those pathogens or they'll clear those pathogens. So basically there are two mechanisms in this area, which is mucociliary clearance. So mucociliary clearance as well as some local antibacterial factors which were present in that tracheobronchial area, those will kill the pathogens or they'll clear the pathogens. The next, the first one was hair and the turbinate of the nostrils will capture the particles. The next one was the mucociliary clearance as well as the local antibacterial factors will kill the pathogens. The third one is the gag and the cough reflex. So it is obvious that when we inhale some kind of dust particles or any particles which are filled with pathogens or whatever it is, so when we inhale those, the body will gag, meaning we start to cough and we start to basically protect ourselves from inspiration of those pathogens. So this is a third mechanism whereby we will protect ourselves from the pathogens. The fourth pathogen is the normal flora which were adhering to the mucosal cells of the oropharynx. There are some flora which were present in the mucosal cells of the oropharynx. These will prevent the pathogens from binding and decreases the risk of pneumonia. So these were the four primary mechanisms which were involved in the survival, or which were involved in the prevention of the inhaled particles to the lower respiratory tract. So all of these barriers, those this hair and the turbinate of nostrils, branching architecture of the tracheobronchial tree, which were mucociliary clearance as well as local antibacterial factors, the gag and the cough reflexes, also the normal flora, all these are the barriers. These barriers overcome, or when microorganisms are small enough to be inhaled at alveolar level, resident alveolar macrophages come into picture now. So these resident alveolar macrophages are extremely efficient. They are strong they are strong persons which are extremely efficient at clearing as well as killing these pathogens. So once engulfed by these alveolar macrophages, So these alveolar macrophages will engulf those pathogens. Okay, so when these alveolar macrophages come into picture, when all those four primary barriers, when they overcome or when they are not sufficiently working, then these alveolar macrophages will come into picture. So these alveolar macrophages, they'll engulf the pathogens. They'll kill, they'll eat those pathogens, and these pathogens are eliminated via mucociliary clearance or lymphatics. So obviously the pathogens are now eliminated and there will be no longer represent a infection. Okay, so only when the capacity of the alveolar macrophages to ingest or to kill the pathogens is exceeded, so all those four barriers overcome, alveolar macrophages came into picture. When these alveolar macrophages, if they are not working properly, or if the capacity of those alveolar macrophages is exceeded, then what happens? Pneumonia becomes manifest, meaning the symptoms of the pneumonia will come into picture. So these alveolar macrophages, what they do is they'll initiate an inflammatory response to strengthen some lower respiratory tract defenses. So the mechanism of action of these alveolar macrophages is they'll just initiate an inflammatory response to strengthen the lower respiratory tract defenses. So the release of these inflammatory mediators such as interleukins, tumor necrosis factor will result in the manifestation as fever. The chemokines such as interleukin 8 will stimulate the release of neutrophils and their attraction to the lung. So what happens is the chemokines, so the inflammatory mediators like chemokines, once they are released, the chemokines example is interleukin 8. Once they are released by alveolar macrophages, what they do is they'll stimulate the release of neutrophils, and they'll also activate the neutrophils to go and bind to the lung, thereby producing both peripheral leukocytosis, meaning increased number of leukocytes at the periphery region, and also increased purulent secretions, meaning increased sputum secretion. Thereby we can expel those pathogens in the form of sputum. So the inflammatory mediators which are released by these alveolar macrophages and the newly recruited neutrophils create an alveolar capillary leak. So this alveolar capillary leak will thus result in an radiographic infiltrate, meaning there is some clicking sound when you detect it on auscultation. So when a patient suffering from pneumonia, when we detect under auscultation, there will be some clicking sounds. That is that shows that there is some alveolar capillary leak in that patient. So this was all about pathophysiology. Next we will study what are the types of pneumonia. So basically we have studied there are three types of pneumonia, that is community acquired pneumonia, hospital acquired pneumonia, and ventilator acquired pneumonia. So we'll be studying these three types of pneumonia in detail now. Here in this types we will be studying etiology, what are the etiologic pathogens or how this pneumonia is transmitted, and what are the pathogens that are involved in the transmission of community acquired pneumonia, and also their clinical manifestations. So the first one is community acquired pneumonia. The etiologic parameters are bacteria, virus, and some fungi. Also there are some protozoans which are under study now. So the patients who are outpatients, basically not hospitalized patients, outpatients meaning the patient is not hospitalized, meaning he has come from the outside, he is an outpatient now. So if we study the pathogens, and those include Streptococcus pneumoniae, Chlamydia pneumoniae, Haemophilus influenzae, and some respiratory viruses include influenza virus, human metapneumovirus. So these are the pathogens which are causing community acquired pneumonia in case of outpatients. Now in case of hospitalized patients, the pathogens include Staph aureus, Chlamydia pneumoniae, Haemophilus influenzae and Streptococcus influenzae. So these are the etiologic parameters or etiologic pathogens which are causing community acquired pneumonia in case of hospitalized patients. What are the clinical manifestations of such patients who are suffering from community acquired pneumonia? So patient will be febrile, meaning he will be having fever. Febrile means fever. He will be having tachycardia, increased heart rate, and also some history of chills and or maybe in some cases sweats. So cough is basically, so as we can classify the cough into productive and non-productive. Productive meaning the cough with sputum, non-productive is cough without sputum. So here in case of community acquired pneumonia, patient may suffer cough with non-productive or with productive of mucoid, and also purulent meaning cough also has pus. There will be mucus or without mucus, but purulent means pus or blood tinged sputum, meaning the sputum will be reddish in color. So if pleura is involved, patient can experience pleuritic chest pain. Obviously, if pleura is involved, then he'll have pleuritic chest pain. Also, there are some gastrointestinal symptoms which include nausea, vomiting obviously, and diarrhea. And there are some other symptoms which include fatigue, headache and myalgia, which is whole body ache, whole body pain. So in case of severely ill patients, they may have septic shock, and also in some cases there may be organ failure. So, and also there are some cardiac complications which include myocardial infarction, coronary heart failure, also arrhythmias. So these are the clinical manifestations which a person can manifest in case of community acquired pneumonia. The second type of pneumonia is ventilator acquired pneumonia, and the etiologic parameters or the etiologic pathogens include both multi-drug resistant as well as non-multi-drug resistant bacterial pathogens. So in case of non-multi-drug resistant pathogens, Streptococcus pneumoniae, Haemophilus influenzae, methicillin-sensitive Staphylococcus aureus, E. coli and Klebsiella pneumoniae. So these are the non-multi-drug resistant pathogens. And the next one is multi-drug resistant pathogens. So the pathogens that are resistant to more than 2 drugs. So those include Pseudomonas aeruginosa, methicillin-sensitive Staph aureus, carbapenem resistant strains, Aspergillus species, and also Legionella pneumophila. So these are the etiologic pathogens which are causing ventilator acquired pneumonia. So the clinical manifestations include fever, leukocytosis, meaning large number of leukocytes, increased respiratory secretions, and also pulmonary consolidation. So other manifestations include tachypnea, tachycardia, worsening oxygen, and also increased minute ventilation. So the third type of pneumonia is hospital acquired pneumonia. So the pathology include, or the etiological pathogens include, the most common causes of hospital acquired pneumonia are gram-negative bacilli, for example Enterobacteriaceae, and also Pseudomonas species. So the most common causes of this hospital acquired pneumonia is gram-negative bacilli and also Staph aureus. So what are those gram-negative pathogens? That is Pseudomonas aeruginosa, E. coli and Klebsiella species. And some gram-positive pathogens include Streptococcus pneumoniae, Staph aureus, including methicillin-resistant Staph aureus. So these are the most common causes of hospital-acquired pneumonia. There are both gram-positive as well as gram-negative pathogens. So, the clinical manifestations of the hospital-acquired pneumonia patients include sepsis, and also obviously there is some respiratory failure in case of hospital-acquired pneumonia. Now, obviously we have to study the treatment of these pneumonia. The first one include community-acquired pneumonia. So how do you treat these patients who are suffering from community-acquired pneumonia? So we will differentiate into outpatients as well as inpatients. So outpatients, there are two ways actually. So in case of outpatients, those who are previously healthy and no antibiotics were taken in past 3 months. They are extremely healthy and they have not taken any antibiotics in past 3 months. So for them, we can give clarithromycin 500 mg per oral 2 times a day, it is BID, or we can also give doxycycline 100 mg per oral 2 times a day. The second way is the patients who are suffering from comorbidities like hypertension or diabetes or any kind of comorbidity, or if they are or if the patient has been taken antibiotics in past 3 months. So for those cases, we have to give fluoroquinolones, for example, moxicillin, any kind of fluoroquinolone, but basically moxifloxacin is given, which is 400 mg per oral once a day. Or we can also give high dose of amoxicillin, which is 1 gram 3 times a day. So this is in case of outpatients. So now we will study in case of inpatients. So inpatients meaning fluoroquinolones can be given, which is moxifloxacin 400 mg per oral, but in case of penicillin allergic patients. So the patients who are suffering from, who are allergic to penicillin, then we can give fluoroquinolones, that is moxifloxacin. And also a beta-lactam antibiotic like ceftriaxone, which is 1 to 2 gram once a day IV, plus a macrolide is given, which is clarithromycin 1 gram once a day. So this is the treatment plan which we use in case of community acquired pneumonia patients of both outpatients as well as inpatients. Now, in the treatment of hospital as well as ventilator acquired pneumonia. So let's study now. So there are actually, here we can see 2 columns, but we can choose any drug of the 2 columns. So for example, if we take piperacillin and tazobactam, along with this drug, we can use any of these 5 drugs. Along with this piperacillin, tazobactam, we can use any of these 5 drugs, that is amikacin, gentamicin, tobramycin, ciprofloxacin or levofloxacin. Like that, if we take cefepime, then along with the cefepime, we can take any one of these drugs. So this is the treatment plan in case of hospital acquired and ventilator acquired pneumonia. So this is all about pneumonia. Thank you so much for watching. Like, share and subscribe to my channel, and I will see you in the next video. Bye.